Hi everyone, this is Mr. Neil Writers here, consultant audiologist and director of ClearWax. Thank you for joining me in another demonstration video of our recently developed WAXscope, which is due to be launched in early autumn of this year. So if you are interested and want to be added to our mailing list, please do email info@clearwax.co.uk. So this is a patient who attended with really impacted wet earwax and dead skin directly on the eardrum. So they've been using various softening agents, so not only olive oil but hydrogen peroxide and sodium bicarbonate, but in addition they've been using a cotton bud, and this has really lodged this wet, sticky, slimy wax and skin right on their eardrum, which always makes it obviously a bit more challenging to remove. And they have in addition got quite a narrow ear canal. So I'm just using our smaller speculum, the 3.5mm speculum, and you can see we've removed the blockage there, so the occlusion's removed, the eardrum is visible, but it's very wrinkly, and that can quite often happen if you have waterlogged in your ear, or if you use excessive amount of earwax softening drops. So the outer layer of the eardrum, it's the same skin that lines the inner 2/3 of the ear canal, the epithelial layer of skin, and in response to prolonged exposure to moisture, it can kind of almost wrinkle, similar to when we shower and the tips of our fingertips become wrinkly. So I'm just removing some dead skin from the roof of the ear canal. This is more mid-canal, and I'm just using the fine end sucker here. So it's a fine end gauge 18. We're just going to be careful, don't want to make contact with the canal wall. So although the eardrum is visible, it's very murky. It's got this wet, slushy wax stuck and adhered. So we're just trying to remove some of this now. So we're just going to the anterior inferior portion. You can see how we just suctioned that off the eardrum and it's just become a bit more visible. Now, there is some wet wax also lodged in the anterior recess, which is a little cave that most of us have at the front part of the ear canal. And the difficulty with the anterior recess is, one, visualizing it, and two, then being able to position the sucker in that cavity, because you've got the anterior canal wall that's protruding outwards and then it dips back away, curls away, and that's what creates the recess. So in a minute you're going to see the sucker, I've bent the tip of it, and by bending the tip, you can see it now, by bending the tip I can curl around the anterior canal wall, so I'm not going to make contact with the canal wall. And I'm just trying to hover over this wet wax. So they've got a very narrow canal here. So the patient can hear significantly better already. The eardrum would just have to dry up now because it's become so wrinkly. I've advised them against using excessive amount of drops because this is what can happen. And the drops typically get lodged deep in the ear, in the anterior recess and also in the inferior recess. So most of us have a little trench, a little basin just at the floor of the eardrum. So you can see we just bent that tip again. We managed to get some more wet wax out. So I'm really happy with that. There's a bit of staining there, but that will dry up. So that's the patient's right ear treated, and this is their left ear. And in here, they had also been using a cotton bud to the left. You can see how they've pushed it in, but they hadn't been using any drops here. So this is a lot drier and it's a lot more matted. It's got loads of skin. So this is really adhered against the canal wall. So I just got a good suction grip and I'm just manipulating this dry wax and skin. It almost looks like a haystack with all these hairs that are matted, and this extends all the way to the eardrum. We're just loosening it. I think it's just blocked my tube there. So again, just using the specular to dilate the ear canal. And we're just making these little concentric circular movements with the sucker just to detach this wax. So they do have a bit of otitis externa, a bit of eczema of the ear canal, so loads of dry skin flakes. They have got some medication for this from their doctor, but it is a chronic condition and it's hard to, in some cases, to keep on top of and to completely resolve. It's something most often you have to manage. But the key thing is to keep the ear dry. So again, we're just peeling this off the back part of the ear canal. So you can see even with the smallest specular size, meant for really small ears like this, we've still got a really good view. We can see the whole sucker. The sucker's got the whole freedom of motion and mobility and maneuverability. So I've just angled the sucker more to the front part of the ear canal. Now I'm just going to tease this away gently. And I'm always trying to lift the wax away from the canal wall into the centre. You can just see by the ear canal colour it's quite red, and that's the otitis externa. So it is a superficial form of otitis externa. And it just means they're going to get a regular build-up of dead skin that's collecting in the ear. So again, I'm just dilating the ear canal. I'm just stretching it as well so I can see the front parts. I think it's lodged here in the anterior recess. So whereas previously we're looking at the back part of the ear canal when we're looking at the front, and you can see that's just loosening away. And there we are. So just going to go back in, have a look at the eardrum. So you can see the eardrum's dry here. There's no wax that's impacted. It's not stained in any way. We've got a good view there. We're just manipulating the speculum so we can see the entire eardrum. Just want to make sure there's no abnormalities that we don't want to miss. Well, I hope you enjoyed that video, guys, and it gives you a good demonstration of how the WAXscope can be used in your clinical practice. If you are interested, as mentioned, please do email info@clearwax.co.uk.